So at this time, task force, I'm going to ask Dr. Walker if she would assume the chair this morning to facilitate the meeting, and I will resume the position this afternoon at our 1 o'clock session. So Dr. Walker, you have the chair.
Yes, thank you. And I want to ask LaTanya if she would, since it's hard to chair and record at the same time, if she would capture, the general topics and any motions that we make today for the minutes. I would appreciate that. So do we want to call roll first? I will do that. I know this is a continuation of yesterday's meeting, but I just would like to know who's here. Reverend Gray, I see you. Adolphus, I see you. Is Senator Nasheed on?
Yes, I'm here.
Okay, awesome. I see Alderman Vaccaro. Is Alderman Boyd on?
I'm here.
Thank you. Is Pastor Norris here? Okay, and I think he might have to join us later. Is Tracy here?
Yes, I'm here.
Okay, thank you. Brad is here. I am here. I think that's everyone. Did I miss anyone? Okay.
Hey, Madam Chairman, for just clarity, hey, Tracy, I'm thinking I'm seeing you on here twice. Is that? I'm looking at the participants and I see your name twice.
She's extra special.
That's because I am outside and I'm in my car, and that is in my house. So when I come back in my house, it'll be
Oh, all right.
That's
Okay.
okay. It's okay.
Yeah.
All right. It's just me. It's just me. No eye spies. I don't got no eye spies going on. It's just me.
I'm sorry.
Miss Davies, if she's on, healthcare.
Yeah. Oh, yeah. And also on Zoom is Miss Davies from the healthcare company that provides health services.
And Maria O'Neill, Regional Vice President.
Thank you so much. So we start with health this morning.
I think so, so we can make good use of their time.
Yeah, I'm gonna let Brad kind of lead some of the discussion. Everyone is welcome to ask questions as we move through this. I will say that we heard some themes as we talked to detainees, and one of them was recreation restrictions. One is family visitation. Those, I would say, are the most elevated and concerning. The other one is how to access, when to access, how timely access is to medical services. A lot of, I think, confusion around that, as well as, just getting access. And the fourth is nobody likes the food. It's not palatable. They don't like the way it's cooked, and they don't like what they're served. So we talked about that a little bit yesterday, but I'll turn it over to Brad for medical.
Okay, good morning. So we have a number of tasks to talk about this morning. It would be facilities, equipment, pre-trial length of stay, COVID-19 discussion, and medical. Any activities and privilege discussion we want to have, and budgetary staffing. But just to make sure we can use, we have the medical staff here at the table and online, so we want to do them first so they can get on with their day. But I think generally, what we would like to hear from the medical staff is, just to summarize, we have the memos from online as far as how you went about the COVID restrictions in the facility, and we'd like to hear about your experience in mitigating COVID and how that was managed. And then I think generally, as far as the healthcare provided here and any challenges you may have, and what's being done to mitigate those challenges. That's kind of what we'd like to hear starting out, and then of course we'll have follow-up questions.
Sure. And I want to kind of set the tone for those of you that haven't been in meetings with us before. Our task is limited to 3 tasks. This isn't a total corrections operations review. We're focused on those tasks. One of which is what contributed to the uprising, and what those kind of concerns are that are adding to that stress. And we're not on a witch hunt. We're not looking for somebody to blame. We're trying to figure out how this pressure has built over the last year due primarily to COVID, and what you need, what the detainees need, what the guards need, what Commissioner Glass needs to address some of these issues. With that, thank you.
Okay, so I'll speak to COVID. I think you wanted to know how we address and were able to mitigate the COVID outbreak. And it was a joint effort between medical and custody. We met at least weekly, sometimes multiple times a week. And we followed not only the recommendations from the CDC guidelines, but with guidance from the health department. And we took it from not only our patients that were already in the building, but really who was coming into the building. And we knew we had to attack it from all different sides. So we worked out a plan for our new arrivals, as well as our people who were already in the building. And we put in place a 14-day quarantine for everybody who was in the building, who was coming into the building, before they would go into general population. And that was just a simple, they were on their own timeline for 14 days. They were not to mix with other people in case they were to start showing symptoms, feeling symptoms. If they reported symptoms, then they were to be isolated and tested. That was how we were keeping the outside from coming in. For our population inside, they were tested at will. If they wanted a test, we gave them a test. They didn't have to have symptoms. We still do that to this day. If they have symptoms, we isolate and test. If they refuse the test, because they can refuse, we isolate. And as things have evolved with COVID, we have also evolved. In the beginning, our plan was, when COVID first came out, our plan was everybody was going to go to the hospital. That's because we didn't know anything about COVID. We didn't know how the response was going to be. Obviously, the hospitals said we can't handle it, so we had to change our plan. In the beginning with COVID, we required 2 negatives before they could get off isolation. Obviously, the CDC has constantly evolved, so we're constantly paying attention to the CDC recommendations for corrections, because there is a different guideline for corrections. It's not just the public, there is a different set of guidelines for corrections. So we pay attention to that. And we also run everything by the director of the health department to make sure, because our population in our building is smaller, we want to make sure we're doing everything that's the best for this building. And that's how we respond.
Any questions regarding the COVID response or the COVID situation directly to medical?
Just medical. I have some medical questions, but not necessarily COVID. Well, sort of COVID too. Are you open to just whatever questions, including COVID questions?
I think just COVID related at this point until they present on their general medical.
Okay.
Yeah, I have a question. To date, how many COVID outbreaks have we had thus far? To date?
Outbreaks, I would say the director of the health department has characterized that we've had 2 outbreaks. And those have been less than 20 people at a time.
Total of 100 positives since the start.
Yeah.
Thank you.
How often are the staff tested to make sure they're COVID free?
Yes.
Yeah, we do not test our staff.
You don't test the staff?
No, we do not. We allow them to test as they need as a member of the community, whatever's going on in the community applies to them as well.
Hey, can I do Alderman Vaccaro, can I follow up on that response real quick? I don't mean to.
Oh, no, that was my only real question.
Okay. Yeah, you said that, I understand you said that you don't do any testing of the staff there at the facility, but do you track whether the staff has been tested or not? And even if they've been, I guess if they've been positive, you have no way of knowing that?
I do not track it. I do know because if they are positive, they notify us. Of course, they wouldn't be at work. And they also notify the health department or the health department notifies us. So the information is shared with us, the health department, and the employee.
And
One clarification on that, Adolphus. Doctors are required to report positives to health departments. So it would be really difficult for the city health department not to know there was a positive staff person.
well, I mean,
Yeah,
that may be the case. I just don't know if those two departments are talking to each other. So I want to make sure I'm clear. You had at least what you would say 2 outbreaks, no less than 20 at a time, and staff had to interact with those individuals prior to them being determined that they were positive, and then staff had to interact with them throughout the process. But that staff that had access to these people were not required to get tested.
We don't require staff to be tested. They're part of the public and they act accordingly, whatever CDC guidelines are. What we do is we isolate the known positive and we provide PPE to staff and the detainee appropriate, consistent with CDC guidelines.
But again, that individual, you found out that they were positive, that's after the fact. But in the meantime, they have been, they've had interactions with staff prior to and with other detainees prior to. And so I guess what I'm trying to say, there's no effort to, and because you could have some staff that interacted with somebody positive who themselves could now be a carrier, and then they are going about interacting with other detainees and other staffs throughout this period. And there's just no sort of effort to isolate or contain any potential cross contamination of individuals within the facility, whether the staff or detainees?
So what we do is the trace screening. So if we have a person, whether it's a detainee or a staff member that is positive, we view our cameras and see if they had what has been defined as close contact. No mask within 6 feet for 10 to 15 minutes is close contact. We look and review tapes to see if that occurred either with detainees and or staff members. And then in the case of both, we interact or work in conjunction with our medical, and we also notify the health department so that they continue the trace process.
And are you confident or have any knowledge with respect to whether those 2 outbreak, what we would call outbreak, my assumption is that they were deemed outbreak based on the number of individuals, but as relates to the total number of positive detainees throughout the facility, of course, the accumulation of that number was larger than 20, even though they may have been small pockets. So I guess what I'm saying, you have no way of determining whether that subsequent outbreak was the result of maybe somebody being positive and having access to some other folks? Because I'm quite sure, let me say it differently. I want to understand what you just said. You're saying that if somebody was tested positive, whether staff or detainee, that you went back into the system, the cameras, and you traced each individual step back to some degree of time, I guess a day, 2 days, or whatever, and you looked at each one of the steps that they took and made a determination as to whether they had a mask on when they was with any of those individuals, or whether they was within 6 feet of any one of those individuals. You did that for each and every detainee and staff as relates to those 2 outbreaks. Is that what you're telling me?
Yes.
Interesting. All right, I'm done, Madam Chairman.
Can I ask just an update on where you are with the vaccine with Staff of Inmates?
So the vaccination is not available. It's not for the state of Missouri, has not been made available for correctional inmates. So that's not something that we have control over. As far as our staff, we were all given the opportunity to get vaccinated at the end of January. That was not something that we required, that Commissioner Glass required, or that Horizon required of their staff. It was an option. 32 of my staff, the medical staff, did get vaccinated and has gotten both doses. I don't know, I don't track custody staff, so I don't know who all got vaccinated on that side.
I could speak to this a little bit. So we were able to get permission through the Director of Public Safety to take a look at how many detainees were on the critical list, and identified 65. And then we ended up actually vaccinating 17 that were willing to do so. In reference to the staff members, because they are first responders, the vaccination was offered to them as well. We did not, it's not mandatory, and some took advantage of that and some did not. And we've actually had our second dose as well.
Do you have numbers?
No, I do not have numbers. I do not track numbers for staff.
I have a question. This is Reverend Gray. I want to go back to the COVID testing discussion. And my question is there something that, is there a law, a policy, something that prohibits the facility from mandating staff to be tested?
I don't know the answer to that question. That would be a question for legal. But I mean, they're citizens. And citizens make decisions about whether or not they want to be vaccinated. I don't know the legal aspect.
I would then follow up then to ask if that information can be provided to us, if whoever may have it, if it is a legal question, I'd like to ask it that information be provided. Any prohibiting or prohibition of staff being it being mandatory for staff to be tested. So that would be my question and my request. Thank you very much.
Reverend Gray, Karen Davies, I just want a point of clarification, because we're talking about it seems we're talking about two different things. Is your question, can we mandate that we mandate testing or mandate vaccinating? Because those are two very different things. And
you're
I
right.
just want to clarify.
I understand, and you're absolutely right. No, I was speaking specifically about the testing. I do understand that you can't force people to do the vaccination. I understand that, but my I guess question is, in some government facilities, I would think that, as Dr. Pruitt said, because of the interaction and the closeness of the detainees and the staff, that there may be a requirement, or there could be a requirement or a mandate for staff. So I'm clear about that, and thank you very much for the explanation. So it is specific to testing.
And
Bill,
Mike,
can I add
Be
something?
able to clarify something around this. The way the process works for any business in Missouri, or anybody who is a close contact of someone who is positive, it gets reported to the local health department that the person is positive. They are supposed to notify their other close contacts. There are places that have been, then the health department, it will offer them testing. They go to the health department to get tested. If they get tested and they're positive, they're in quarantine for 7 days now. If they are not positive and they're in close contact, they're still in quarantine for 7 days. For a while, CDC was saying you had to have 2 negative tests to go back to work. They're no longer saying that. They are now saying if you're in quarantine for 10 days, you can go back to work whether you have negative tests or not, if you don't have signs or symptoms. So they're really sort of backing away from the testing. And the reason they've done that is because testing is just a point in time. If we tested all the guards today, we might find some that are positive. We might find 95% that are not, but that doesn't mean they won't be tested. They won't be positive on Monday because they got exposed to somebody over the weekend. So the most effective process that CDC is now recommendation is screening for signs or symptoms and immediate isolation and quarantine if you have signs and symptoms or if you are a close contact. So, you know, they've just learned a lot about this, about how it's transmitted and how testing may or may not help manage, you know, situations like corrections with that. The second thing is, it is an invasive, and I think we've discussed this a little bit as far as the detainees are concerned. It's still a very invasive procedure where you have to go up into somebody's deep nasal cavity to get a sample. And under Missouri law, you can't force someone to do that. You know, not for a DWI, not for HIV/AIDS, not for tuberculosis, nothing. Can you force, you know, our rights stop at their nose, basically. So that's just kind of perspective. I think we should still ask the question, and they're good questions to be asking. But CDC is kind of getting away from mass testing as a management tool.
And to add to that, part of the reason they're no longer requiring 2 negative tests is because you can shed the virus, non-contagious virus, for up to 90 days. So you can test positive for up to 90 days, but not be positive, not be contagious. So if I contracted the virus in January, but get tested again to come back to work or to be let off isolation, I can still be testing positive, but not necessarily need to be isolated because I'm no longer contagious. That's why they moved away from that and they're just saying quarantine for 10 to 14 days. Once no fever respiratory symptoms have lessened, you can be let off isolation.
And the local health department makes that decision about when somebody can return to work.
I think Tracy, Madam Chair, I think Tracy was trying to get in on the conversation.
Oh yeah, I can't see the
I understand.
So yeah, please do that for me in the office.
Yeah,
Somebody raising their hand, let them in.
yeah.
So my question basically was a follow-up because he said that when he would look on the camera and see whether they had a mask on or not. So what was the implementation process with everyone wearing PPE inside the facilities?
I didn't hear the question.
Let me try to rephrase it, Tracy, and see if I get it right. She said that you looked on the video to see if people were wearing their masks. So what is the situation on PPE? You know, and why wouldn't they be wearing a mask?
I think the question was also, when was that implemented? Is that correct, Tracy?
That's correct. And how was that process? I mean, how was that protocol implemented? Because he may mention he would look on a camera to see if they had a mask on or not.
Okay, so I think I understand. A couple questions might have been in there.
Yeah.
And Christina, speak up if I don't get this accurate. But we started with the mask as soon as CDC said we should be wearing masks. We provided them to both staff and detainees. We provide everybody that comes in this building a mask if they don't have one. And that is still the practice. We provide 2 masks every other week, 4 masks.
2 masks a week.
Yeah, 2 masks a week, but they can request a replacement at any time. So that was at the very beginning. And so was the observation of the camera. And the reason that there were 3 things we were looking for, because the health department directed us or gave us a definition of what to be looking for in terms of close contact. That was wearing a mask within 6 feet and in that close contact for 10 to 15 minutes. More than 15 minutes. So that was the baseline and what we were looking for when we went on camera. And why would we be looking for without a mask? Because sometimes people won't wear their mask. And we have to remind them to put their mask on, just like in the community.
Thank you.
Ask incorrectly.
Yeah.
Hey, Madam Chair, I have one last question, and I guess it's fairly simple, and anybody can answer who think they can. You know, when a lot of this stuff started happening with the uprising, I don't know why I can't find a different term. Some people use riot, some people use uprising. I don't know what is a good term, but a lot of that we heard from detainees saying it was centered around COVID, testing or lack of PPE or all this other stuff. From your side of the table, can you respond to that overarching theme that COVID and how the facility was responded to detainees as relates to the COVID? Why would they feel so upset about it that it rose to a point where they became, I guess, uprising, I guess, for lack of a better term. But I'd like to get your side of the story as to why so much of an issue about COVID that they felt that they needed to respond that way.
I can't speak to why another individual chooses to answer a question a certain way. I can tell you what we've experienced interacting with the inmates. What we've experienced is that they are exhausted and tired of the restrictions. That's what was prevalent when we have our wing rep meetings and going to the units with caseworkers and medical. Some of the things that Walker mentioned, we also found that visits was an issue. We found that court appearance, delaying court appearance was an issue. And the fact that they weren't able to be out the room on recreation as long as they had been used to in prior to COVID is what we continue to hear as feedback. There was some anxiety related to the unknowns about COVID, just like we find in the community, and we try to speak to that. But it's been going on for a year, so we became repetitive in our responses. I think that's what I understand and that to be, but I can't speak to why they responded to you guys differently or in the community differently. I can't speak to that. I do know that they would sometimes ask questions about who's positive, you're not giving us enough information. But I think that we did a pretty good job of quarantine and isolation. There was one period of time where some were in the same unit, but yet we were still observing the rules as it related to what close contact looked like, cleaning. We've got an air filter system in the whole building, and we sprayed the whole building, both buildings, every other week, have been for several months. So that's our reality. That's what we understand, and we're waiting to hear what you guys find out.
And one quick follow-up, and so you're saying that if we were to ask for all of the complaints that were, I guess, filed through your grievance process by detainees to you guys as related to COVID or COVID-related issues, would they exist? Or are you saying that they did not file grievances or complaints about COVID-related?
We provided numbers. We had probably last year, maybe 20 grievances total. I did not look at them all to be able to tell you. I don't recall reviewing any, but I just can't speak to that right now.
All right, thank you.
Yeah.
We will, when we do our debriefing, we will comment on that as far as our findings, as far as that question, as far as what we're hearing from the detainees and what we're seeing. We will lay that out pretty clear.
Got it. Thank you.
Can we move on just to, is there anything else COVID before we move on to regular medical care? And the reason we were not here to investigate medical or mental health care, but when we're looking at the isolation issue, one of the common climate indicators that kept coming up, like Pam had said, is that there was some concern and agitation about the length of time it took from the time of putting in a health service request to get seen either by a nurse, and more specifically by the provider, and possibly some issues with follow-up to get medical orders implemented, whether it's lab work or any other medical orders. So just like what's your belief on the care that's being provided and how that's being mitigated, and what any actions that would be appropriate to. We understand COVID has limited movement and escorts and that sort of thing, but what would you offer to kind of outline that process and mitigation?
So first, let me explain how the process works. The patient puts in a sick call or a medical request, an HSR. That goes in either by paper or by tablet. Once that is received, the nurses have 24 hours to do a face-to-face triage. That's not to answer it, that's just to go and do a face-to-face and say, we received this, what's going on, and to disposition them, whether that to be, they need to see the nurse for the nurse sick call, put in an appointment for the doctor or for the dentist. From that point, we like to have those people seen within 72 hours. Lately, that has been slowed down. Not every person who puts in a sick call to see the doctor needs to see the doctor. There are many things that can be taken care of by our RNs and by our LPNs. And the doctor, Dr. Mallard, has a very hefty patient list. The dentist has a very hefty patient list. So when you get an appointment, just like in the community, you have to wait for your appointment to come due. And on the day of your appointment, if there is things going on within the building, transport to medical to see your provider is not always available. there are things that go on that prevent us sometimes from being able to provide the services on that day. That doesn't mean that your appointment's just thrown out and you don't get seen. You have to be rescheduled, maybe to the next day or to the next week. But we do have a process. We try to stick to that process as best as we possibly can. There are a lot of times where they request lab work. It's not clinically indicated. You know, we get a lot of sick calls. I want Tylenol number 4. It's not clinically indicated. You know, there are things that are requested, but it's not clinically indicated. And that is, I do get a lot of complaints because I get letters written to me all the time about, you know, Dr. Mallard won't give me my pain medication, things like that, upset about things like that. But I do know that due to COVID and other things that our process has been slowed down, and we do our best to catch back up.
How often are nurses in the units?
We have a 4 med passes a day. And then we also do.
Explain that to me.
Okay, so we
Speak
have,
English.
so they do a medication pass. So we go to the units to pass medication 4 times a day. And then we also have diabetic checks twice daily. And then during either the medication pass or the diabetic check is when we try to perform the sick calls. And we don't go into the units, we do them at the sliders now. And then the providers, the dentist and the doctor are in medical and the patients are brought to medical. We also do a 14-day initial health assessment that's done by an RN. That's done within the first 14 days of the patient being here. And then we do an annual health assessment that's done yearly by an RN. That's when they get their TB test. We do a head-to-toe physical, answer any questions, concerns, comments. The initial is when we get a whole picture, a history, a physical, any medications, maybe that they didn't want to tell us or we didn't capture at their intake when they first come in.
And the triage part within the 24 hours, you said, is that a face-to-face or just triage?
Face-to-face. Face-to-face.
Face-to-face. And the 72 hours, that's to be seen by an RN or the provider?
It depends on how they're dispositioned from the face-to-face triage. So they go and they triage face-to-face, and let's say they say, oh, you know, my tooth hurts, and so the nurse will have them open their mouth and say, okay, yeah, you need to see the dentist. So they'll disposition that sick call to the dentist. You need to see the dentist. And so we try to have them seen within 72 hours.
Do you have any
unless
data?
It's an urgent or emergent issue.
Do you have any data on when those goals are not being met or when escorts are not available and things have to be delayed? Do you have any data on that?
Oh, I'm sure I do.
It'd be interesting to see where we're at compared to what we're hearing.
We do track, as Christina, I see her nodding her head, but we do track what our backlogs are on those processes so that we can address anytime we see that climbing, that we do everything we can to mitigate that and work with our security partners to get our patients seen.
With so much nursing being done in the unit, how do you protect confidentiality?
So we're not actually in the unit for these sick calls. Now MedPass is done at the slider and they come out one by one. The nurses conduct the sick calls then. So it's individual, it's one-on-one. So everything's protected then. And then the interaction with the provider is in a doctor's office. They're on their own with the doctor.
So for people who haven't been in the facility or toured it, when she says slider, those are the doors that are locked that lead into the unit. And it varies, but it's usually a smaller room. It might be the hallway. Does somebody want to help me describe that a little bit better?
It's a vestibule.
It's a vestibule. So if you do that one-on-one, that's good.
Yes.
And just to kind of remind everyone that, you know, this facility is NCCHC accredited. So they have the National Commission on Correctional Healthcare accreditation, and their standards are very, very clear as to some of the things that I believe Dr. Walker is mentioning, like privacy, HIPAA, you know, timeframes for rendering care, seeing patients, urgent, emergent, that kind of thing. So And our policies and procedures mirror those standards. So we really do hold ourselves to that high standard, and you know, every effort, even under these conditions, are made to meet all of those standards.
Do you get a site visit here to get accreditation, and how often does that happen?
So accreditation is every 3 years. And I believe that we were slated for the site visit, and that NCCHC had to push that back as related to COVID. But they will be giving us a new date for that survey. And, you know, because of all that's happening in the world, I just actually last week, we just had a site that was surveyed in Kansas, and that site was virtual. That survey was virtual. But I can tell you, having been through both virtual and up close and personal, that this was as taxing as any on-site accreditation. They did a virtual walk through the facility on camera. They sat down, they reviewed everything virtually, files, they went through them, you know, line by line, just like they do if they're sitting next to you. They just happened to be sitting somewhere else, and we were going through it line by line. And they did do inmate interviews as well, so like they do when they come on site. So they're taxed as well, but they're doing they're continuing to do their surveys. And again, I find them to be quite thorough.
I would like to add that we have incorporated the requirement that our healthcare provider remain accredited as part of the contract. And they not only accredited, but the last one was a score of 98 here and 100 at MSI.
Can you comment on whether or not the staffing crisis has any effect on being able to get inmates appointments?
Absolutely. It's a joint effort on both sides, our staffing issues and their staffing issues. I mean, if they don't have officers to transport the inmates to medical, we can't provide the services, just as if we don't have nurses on staff to pass out the medications. I mean, it's a joint effort. And with every incident, with every uprising, staffing on both sides has been affected. This is a very unique environment we work in to begin with. So staffing is always a work in progress. And then when you add bad public relations and bad news, it makes it even more challenging. So yes, absolutely. And then to add to that, with the push of closing the workhouse and things like that, that hasn't been helpful either. Because I'm over both sides. I'm at MSI and I'm administrator for both. And so when my staff feels like they don't know if their job is secure down at MSI, they're not going to hang around. So then we have to pivot and move, and we have a job to do. We have services to deliver, so we make that happen. But yes, absolutely.
You have staffing issues yourself, and are you be able to staff in accordance with the contract right now?
We have a staffing shortage, but our services are delivered.
And I think that's a point that I want to make sure that everyone understands in the room, is that yes, there is a staffing shortage in the medical area, but delivery of services for us and having people available to deliver those services is not optional. I'll point out the fact that Christina herself, thank goodness, is also a registered nurse. So if someone doesn't show up for a med pass, Christina goes out and passes medications. And you know, we have the director of nursing who are traditionally, you know, administrative folks. They put on their scrubs every single day and come into work, just like Christina has right now, ready to work if that's necessary. So we are available to deliver the services. That is definitely not optional. And even during some of the crises, again, struggling for the right word to use, you know, obviously safety is paramount, right, for everyone. So when the facility's locked down, we have to quickly kind of shift and adjust and decide, you know, what do we need to do to get diabetics their medication, because that's critical. And so we worked with security staff to make sure that even though the entire place was locked down, we figured out a way of how we were going to make sure that those critical medications were delivered. So it's a constant, it's a fluid situation, but we stand ready to respond to that.
Excuse me. Thank you, Karen. And thank you all for what you all are doing inside the facility. So you made mention that you all are backlogged. So if you are backlogged, how is it that everyone is receiving those services when it comes to medical and health? And then we have pictures of people that have infections and things like that. And then I just want to reiterate or go back to where, I'm sorry, I forget your name, sir. He said that there were like 20 grievances and he wasn't able to read them all. Are you responsible for reading the grievances, or is it someone else before you, or that before the grievances reached you?
I guess you're referring to me.
Yes, I'm sorry.
No, that's okay. The grievances are handled below my level. If the grievances are appealed, they don't agree with the findings or the comment, then it comes to me for final disposition. And then if the detainee doesn't agree with my final disposition, that gives them access to the court.
Okay, and you said that you weren't able to read all of the grievances that you got that did make it to you.
Yes, I read the ones that made it to me.
Yeah, Tracy, something we heard yesterday from the detainees, and a lady named Mrs. Price, that is, what's she had over? Yeah, she's constituent services, is that there's some confusion over complaint versus grievance versus what goes to laundry, what goes to medical, how people ask for that. And I think we'll be talking about that in some of our recommendations. We ask a lot of questions about that. And as we heard from the detainees, we asked to meet with Mrs. Price, and she agreed to do that. I think she handles a whole lot of stuff just as a complaint. And it never gets actually filed as a grievance. So she does have documentation, but it's not by topic. And I think you asked her for that, Brad, didn't you?
Yes.
Yeah, so Brad did ask her if we could see her documentation on complaints as opposed to grievances. So I do think there's issues there, and we can talk about that more in depth when we get to our recommendations.
May I explain
Thank
that
you, Pamela.
a little bit?
Yeah, Dale asked if he could explain it, so please.
So we get a varying number of complaints, requests. They come in various forms. I mean, it's not uncommon to get a complaint that says, I'd like to work in the kitchen. Well, that's not a complaint. So the way the grievance process is set up is you try to resolve any issues. In fact, it's called an informal resolution request. And you work with the detainee that has that request and try to resolve it. If it's resolved, then it never comes or becomes a grievance. And that's how the process is set up. Once if it's not resolved, they move to the grievance phase. And one of my administrators responds to that grievance complaint. If the grievance complaint is appealed, then it comes to me. And once the detainee has gone through that process, that gives them access to go to court if they don't agree with what I've said. Seldom does anything go through the process and they still are unsatisfied by the time it gets to my level. I don't know off the top of my head, maybe 3 last year, 4, I'm not sure. But we usually are able to resolve it. A lot of times it's just a conversation could have resolved it in the first place. And so that's how that system is designed to work.
Well, I'm thinking that maybe once what Pamela and Brad made mention of finding out with Mitch Price what those complaints look like and the process by which they are getting to you, because that's just not what we're hearing on our side from an enormous amount of detainees. So I guess maybe there needs to be some clarification with what actually gets to you as a grievance versus just a complaint.
And then, Tracy, you said something about backlogs. Can you repeat that, please?
Yes, I believe that I heard you say, or you all say that your services are being delayed or backlogged. Is that not what I heard you say?
So Karen said we track a backlog or backlogs, and what that means is that if we are scheduled appointments, if somebody's scheduled for an appointment today and they aren't seen today, it goes on the backlog. We track that. We track those services. So a H&P appointment, if they're scheduled for an H&P appointment or their their annual physical, and we schedule them, they're supposed to get them yearly. We schedule them at the 11th month to give us that grace period. But if they aren't seen on that day, it goes onto our backlog, and we track that. We track those numbers. So that's what Karen was referring to as far as our backlog.
Okay, and so the process with putting in a request for medical, how many steps does it take before it gets actually to you? The request for medical.
The HSR, the health service request, is put in either on the tablet or on paper. We pick those up. They get printed or picked up daily. The nurses have 24 hours to triage them in person.
And this is something that you all say that you do on a regular basis, and this is being done 100%? Every health request that you all get, is the person is being seen?
It's not, they're not, every health request that we get, it may not be clinically indicated for whatever they're requesting, but every health request we get is being answered.
So just as an example, Tracy, when she says not every person needs to be seen, if someone says, I want my diet changed, or I want a kosher diet, that person doesn't need to be seen. We do need to respond to that request, but the person doesn't need to be seen. So the answer to the question is that in all health services requests that are submitted that require a face-to-face, the answer is yes, they are seen. And because that is the standard, we have to meet that standard.
Okay, I understand what you all are saying. That's just not what, I mean, we have like pictures of things of people's body parts and extremities that clearly have infections, and they state that they haven't been seen, or that they put in requests and they're not being seen. So I'm just trying to figure out where is the miscommunication between, I don't know if it's the detainees, and you said that the requests are being put in on a tablet or someone that would go directly to you all. I'm just trying to figure out where the miscommunication is, because it's more than one.
Well, it would seem like absolutely, like there is a disconnect, and clearly, and if you have any names, or again, you say you have some pictures, we definitely want to get those people and see, when did they put a request in? Was the request received? And if it was, and it wasn't responded to timely, then we need to find out what the root cause is, and we need to address that immediately.
Okay, thank you.
I have a question more on intake. I'm aware of the updates and all that have been done, and certainly think everything's better than it was 8-9 years ago. But my still thing is, like someone with me that's on heart medicine and diabetic medicine is critical to me. Yet if I come in today, hopefully not ever, but if I come in, I'm not allowed to bring my medicines, even if my family says, look, these are critical. Without these, he'll die. Yet I have to wait to be assessed by your group, which means I can be without critical medicines for 1 or 2 days while I'm waiting to be assessed. That's the only one thing that's always bugged me.
Actually, that's not our process. So that's not our process. When you, well, not you, when someone is arrested, and they come into this facility, they're seen by our nurse within 4 hours. If you report medication, if you have medication, if you say you take medication, we verify that either by the bottle, by the pharmacy, by sending off an ROI. Our nurses will contact Dr. Mallard and we start you on that medication right then and there. There's no, especially critical medications, there's no wait time.
Okay, well, that's changed then, because I do know, like, I'm on 2 different shots, not just insulin. I'm on heart medication. I'm on, I take like a handful of pills just to wake up. Antidepressant, anti-anxiety medicines that I take. And, and I won't go into the story of how someone ended up dying years ago. And that's what really got me interested about, 9-10 years ago. And I went through this with Dale Glass, and I know there's been improvements, but, I do know that some of us take, a lot of medicines. And I guess the medicines that you may not feel as critical are the anti-anxiety, antidepressant drugs, because in this case, when someone didn't get those, and we could argue whether or not that was the case. We had talked about this, and this goes back a long time ago, but the person had committed suicide and died over, and we could argue as to how or why, but that was something that always bothered me, that, when the family says, gee, this person has to have these meds, that they're so important, I mean, I just, and again, I didn't even know how you would get the stuff I take. I take Ozempic, which is, I guess, fairly easily gotten, but I take this Exaltafee, which these pens, either one of those pens are over $1,000.
So we do, sir, we do have a process. I understand your concern, believe me, because we do have people coming in on critical meds every single day. And some of them are very specialty meds, I'm sorry. And so if it's a specialty med that would take time to order beyond the time that you would need it, then we certainly would say, do you have that medication available? And if it's in a properly identified package with the, it's not, with labels torn off and we can't read what it is, if you have that medication, then we make an exception to provide that personal medication until the stock comes in from our pharmacy. So, we do everything to make sure that any medication that is critical is provided. And we do understand that there are some very specialized medications these days, and that's how we handle that. And it's on a case-by-case basis. For obvious reasons, you don't want to just take a prescription bottle and not know what may or may not be in that bottle. So if it's a critical med like you're describing, then we're going to say to you, do you have that med available? We'll take that medication, examine it, order it so that we can get our own supply in.
And I'd like to add, this is Maria, I'd like to also add that we also have a backup pharmacy, that any event that there's a medication that's not in stock and it's obviously there's something that needs to be given, our staff is required to go to backup pharmacy, a local pharmacy, to go pick it up for a couple of doses until the actual ones come from our national pharmacist.
But so, I mean, that's changed because, again, in the past, and this goes back 9 years. So, you could not, they would not let you take in. And just as for instance, some of those medicines I take are, pharmacies don't stock them. That, in other words, they're always special order. So, I have to stay way ahead of it. So I have a supply, but in some of that, asthmatic stuff and that I don't take, but some of that, again, that people have to have with them if they're having an asthma attack, and sometimes anxiety, and my puppy's talking to me over. Anxiety could trigger asthma, that was just my thing. And it seems like maybe it's changed, but I just know
Well, it has changed. It's not, I want to be clear, that's not a maybe, sir. It's a, I mean, you have to believe that, you know, lessons are learned throughout this whole process. I mean, I've been in this industry for 30 years, and I can tell you what we did 30 years ago certainly is not the standard today. And I've learned so many things across this time period. And thank goodness things have changed. And, you know, we want to always be moving in a forward direction and doing the best possible thing that we can do for our patients, because as soon as they come in the door, they become our patients, and that's how we see it.
Okay, well, I mean, and there's been, you know, I will say over nine years, there's been great improvement. It's
Thank
just
you.
been the one thing that's bothered me.
Thank you for answering that. It brought up a question for me. When you said as soon as they come in the door, I have a timing question. There are 3 entities operating in this building: the police, the sheriff, and corrections. And we saw on the 2nd floor, and we are going to talk about this in a closed session for security reasons, but in general, there are holding cells on the 2nd floor that are under the police jurisdiction. Those detainees are being detained by the police. They're not being detained by corrections. They have not yet said, here, they're yours. But some of them have been there for an extended period of time. Do you see them?
Yes,
Do you see them when they come in the door or within
Yes.
48 hours?
we see them within 4 hours of them hitting the first floor.
Okay,
The standard.
so no matter who brings them in,
Correct.
you see them in 4 hours.
Yeah, the
Correct.
standard for the 4 hours is anybody that comes into this building. Corrections provides medical for the entire building,
Okay.
whether there are detainees or not.
Remember when we went to the first floor, to the police
Right.
side, prison processing side? And I showed you where the inmate, the arrestees would come in with the police, the
Right.
holding tanks there. It had the thing right there, new arrivals, seeing medical, ready to go upstairs.
Okay.
There's a medical unit that's right there that once they come in, they're being seen at that, it's the initial medical phase. To where they come in and ask those questions, medications, what are your thoughts about this?
They're not supposed to go to the 2nd floor.
Right,
until
they're
they've
not supposed to go
seen
to the
nurse.
2nd floor until they've seen the nurse.
Okay.
But those people will still be in police's
Yeah,
custody.
that is to determine whether or not we're able to provide the care that that individual requires. If we are not, then we have the police take them to the hospital and stabilize them or determine what's going on before we allow them to be in
So
this
that's
building.
their responsibility.
To take them back to the hospital. We make the determination and then they take them to the hospital.
And
Okay.
I'd like to just
Oh, I'm sorry, go ahead.
thank you for pointing that out about taking them to the hospital if there's some question as to what their needs are. Part also of that, as a result of that intake assessment, when someone cannot tell us what their medication is, if they cannot tell us where we can get the records for their medications, which happens more times than I'd like to say, we don't just leave it at that. Whatever they say their condition or problem is, they are monitored, be it blood pressure checks, our asthma watch protocol, put them on our list for diabetic finger sticks. And we start to treat that condition here based on our assessment. And if our assessment indicates that some specialty care or medication may be necessary, that is a setting in which we will send them out to the emergency room, or they can do a faster and more thorough evaluation than we can do here to help get them started on whatever medication they need while they're here.
Okay, that leads me to a budget question. So we've heard that on average, there's 75 arrests a day in this building. Do the police or sheriff pay any costs of medical care? If they take someone to the hospital, who pays for that? Corrections pays for that?
I mean, I can determine where that question goes, but I can say that I looked into that issue, and this is the city. The police is the city. Corrections is the city. So the city pays for those bills through corrections. We hire the contract provider, and and have had that contract, hold that contract with them. So we provide it. And the other thing that I learned during that process is that the police do pay medical, but that might be someone they arrest on the streets, don't make it here, and they pay. But when they come to this building, we assume the cost. It's free.
That's all built into our budget.
It's written into my budget, but it's the city pays, and that's the way they pay.
I have a question. I want to go back to the requests, the medical requests that are made that may not be medically indicated.
Mhm.
Could you talk a little bit about that process? Because obviously there's some disconnects there. Someone says
Sure.
they need something.
Sure.
You say they don't.
Right.
So could you talk a little bit to that process?
So, the easiest example for me to give you is somebody's requesting ibuprofen or Tylenol. And there's contraindications for someone to take ibuprofen or Tylenol for very lengthy points of time. They've seen Dr. Mallard. This is Dr. Mallard, this is our provider. We didn't do introductions today, but this is Dr. Mallard. And I'm the administrator for everybody on Zoom. And so what will happen is the nurse will do the face-to-face triage and say, what's going on? I received your sick call. I want my ibuprofen or Tylenol back. Okay, well, I just have pain. I have generalized pain. Okay, we'll put you in for a nurse sick call. We don't just leave it at that. We have the nurse see. So then they do the nurse sick call. The nurse goes through the sick call. There's a encounter tool that we do for charting.
Is that MedPad?
And when the sick call is conducted, is either at MedPass or at when we do diabetic checks. It just depends on what's going on in the building that day, what time's allotted for us. But throughout the day, sick call, the triage is done on the evening shift. Sick call is done the next day on the day shift. When the sick call is done, the nurse will go through the body systems, whatever the general complaint is, get a set of vital signs, check over everything. If it's not clinically indicated for Tylenol or ibuprofen, the nurse will say, there's no clinical indication for you to receive Tylenol or ibuprofen at this time. And we leave it. You can access medical again if your symptoms worsen or you continue. Please contact, put another sick call in, have you see the doctor. But there are certain things, just because you ask for something doesn't mean that it's medically necessary for you to receive it.
I just want to know that process and how much of that is the judgment on the part of the person seen, or the nurse, and how much of it, someone says, I'm having back pain, or it's not like you're rushing off to get an x-ray.
Right. We go through, so the nurse will pull up the patient's chart and see that they've been on ibuprofen for 6 months, right? We refer them to the doctor because you can't go see okay, you've had this issue for this long, you have to see the doctor. Then the doctor makes the determination from there. That's over our head as the nurse of what's going on. Everybody in the medical field knows pain is what the patient says the pain is. And that from there, the doctor has to decide, where does she go? What do we do with this patient? And that's where we go. Ibuprofen and Tylenol is available on commissary. So just because it's not ordered by us doesn't mean they can't get it for themselves. If there's not a clinical indication for the doctor to order it, there's not a clinical indication for the doctor to order it.
I'm gonna ask Brad to summarize real quick what else we need to get through this morning.
Hey, I got one quick question, Madam Chairman.
Yes, sir.
I just want to make sure I understand from a structural standpoint, who is who and who reports to who. Because my assumption is that on the medical side, that you have both the contract side and then you have folks who direct reports or work for Commissioner Glass. Am I right or wrong?
I can answer that.
Yeah.
So all the medical staff are contract providers, all medical staff, contract providers, and they work for me.
And they and they all report to you. And so I guess my question is, and I'm not trying to put the contractor on the spot, but from your standpoint, are there things that you think you need that are not happening that you need that will make your job a lot better and you provide the best care, not that you're not, but the best care possible for your detainees, and or the requests you're making of Mr. Glass or the city that are going unfulfilled that you need in order to do your jobs? And you can say it in front of Commissioner Glass. He's not going to retaliate.
I'm very comfortable. We have the commissioner and I, actually all of the administrative staff on the custody side, we have a very good working relationship. I'm never afraid to ask for anything we need. COVID obviously has made things difficult. I've never managed through a pandemic before. And it's been a moving target, and we've done the best that we can do. The numbers, I believe, speak for themselves. We need some stability and security, but that's not anything that just Commissioner Glass can give us. Obviously, nothing's ever perfect. I would love for it to be perfect. You don't know me, but I am somewhat of a perfectionist, as is my doctor, Dr. Mallard. But we're always trying to be the best. But we work together, and that's all I can ask for, is that we continuously work together. Major Harry, Mr. Hayes, Kim, we all have the same goal, which is to provide the best medical care to our patients that we can. And we strive every day to do that.
And I know you want to move on, but I would say my take on that issue is that I tell Horizon, these are your patients. Let me worry about them being detainees. You worry about them being patients. So that's our approach.
And I don't want to cut this off because it's a very important subject. But I want everybody to hear what we're trying to get through this morning. And if you want to continue this, we'll have to talk about how we get to those other things. And I want to be respectful of everybody's time. So Brad, just summarize that, and then I'll call and see if anybody else has any more questions.
Yeah, the other topics we have to get to this morning are the facilities and equipment discussion, discussion on pretrial length of stay, activities and privileges, and budgetary staffing discussions that we want to get through. So,
yeah, and I want to do this in the open meeting part. I want to make a recommendation on recreation, relaxing the recreation requirements, and visitation for program, not visitation, but program people possibly coming in under certain conditions. I want to have time to discuss that, make a motion on it, ask your permission, if it passes, to possibly share that recommendation now with the mayor and Commissioner Glass, because I think it is urgent. It is an urgent situation based on what we're hearing from both detainees, officers, and administration. So are there any more questions from the medical people? Because we may not get them again, especially people that are on Zoom. And I can't see it. Office, can you see it?
No, I think we're done. No, we're done.
Okay, awesome. All right, well, thank you so much. Thank you for what you do and for being willing to sit down with us and get grilled. If we have more questions as we move through this process, we will circle back around and ask you.
thank you. Pam, do you want to? Can I just make some initial comments?
Yes, yeah, I'm throwing it back to you.
I think to move this along, if we can, we'll get to Pam's recommendation right away, so we make sure we get that in this morning. But I just want to preface this this afternoon's meeting is specifically about our findings due to the COVID isolation and recommendations we have moving forward to that. So we have a number of findings, and obviously that's one of the #1 education issues here for the inmate population that, in our opinion at least, led to the behavior and the disturbances. And we'll have recommendations for that, but Pam would like to relay one concern and recommendation this morning so that she can begin to process that. So I'll just turn that issue over to her and then we can get that. Oh, I'm sorry.
Yeah, they can leave. You can have your day back.
Go ahead.
Yeah, Madam Chairman, I so move that we move ahead with your recommendation as relates to relaxing the recreation requirements.
Okay, yeah, we heard from, one detainee said, if you address the ability to meet with family on Zoom and you address the recreation requirements, 90% of this will go away. Now, I hope he's right. I hope he was right. It was very optimistic. But so I spent the last 2 days looking at the CDC recommendations, looking at not only what they've submitted in writing as related to their COVID practices, their response to the questions I had about that, or uncertainties I had about that, what the detainees have told us about themselves being in quarantine, testing, vaccination, other things, and their number of cases. And I feel like they have it down really well. They basically locked down more than any other jail or prison that I could find, which contained their cases for both, I think, the guards and the inmates, and much more so than the state here anyway. So what I've come up with is the CDC's language is really specific to requiring isolation practices for places that mix their units and mix activities between units. And the way they're set up here is their units are very contained. And you've heard people talk about stay in your bubble, stay in your, people you're exposed to every day, have Christmas with your family that's in your bubble. Well, you've got 63 people on a unit that's in a bubble. They don't go anywhere. They've not been exposed to anybody. And I don't see a reason why they can't recreate together. The current situation is very restrictive. They get 45 minutes twice a day. And in that 45 minutes, they have to make phone calls, which are, you either get a 15 or a 20-minute phone call. They have to take a shower. If they've bought food to the commissary that they want to eat because they don't want jail food, they have to have time to cook. They cannot get that done. And it's very frustrating and very mentally taxing. And I really think that the risk to their mental health, their stress, and the potential for another uprising totally outweighs not relaxing the restrictions. So what I'm recommending is that they continue the 14-day quarantine for anybody that comes in. Anybody coming into a unit has been quarantined. They do not mix units. They don't let them recreate together. They don't let them have programs together. They stay within those units. That they get 4 hours a day. And how they manage that is up to them. But talking to the major and some of the other guards, it might make sense to do the top half, the first 2 hours. The officer goes on break. You also have to realize there's only one officer in a unit for 63 or more people, and sometimes less. But so the officer goes on break, and then the people in the bottom come out for 2 hours. Officer goes on break. The afternoon, you do it again. So they're getting a 2-hour segment twice a day instead of 45 minutes twice a day. The other thing I'm proposing is that they allow some program people back in with proof of vaccine. So ministers, teachers, social workers, you know, we had one person tell us, I'm actually glad to see my attorney because I'm so desperate to see someone. And I don't even like him. And he goes, I tell him, I don't want to talk about my case, what's going on in the world. They really need outside contact. And when we get to the equipment stuff, we're going to ask the commissioner to talk about what they're doing with Zoom and getting that, what they've been trying to do and where they are. We're trying to get that set up. But I think there's a way, and they really enjoyed those programs. I think it helps them cope and prepare for what's coming next for them. And I would just ask the facility to figure out a way to make that happen more within their unit with people that are vaccinated. Now, Brad and I had a discussion this morning. There's news out there that you can still spread it if you're vaccinated. No, you can't. If what the stories are, if you read them carefully, people that got the first shot who were already exposed and get COVID, yes, they can spread it. If you get a second shot, you're 95% protected. You can't get COVID after that second shot unless you were already exposed. And it reduces your symptoms amazingly. But if you can't get COVID, you can't spread it. So someone who's fully vaccinated, gone through their 14 days after their second shot to become totally immune is perfectly safe to let in the building. So they won't expose guards, they won't expose people in the units. So I'd like to recommend that I write that in a more scientific way and be allowed to kind of jump the process ahead of our other recommendations and get that to the mayor now and to the commissioner so that he can discuss it with the city health director and see if we can't move that faster.
And Tracy's got a hand up, Mr. Chairman.
Yes, I have a question. I have a question as it relates, and that those things are definitely stressors of the individuals, of the detainees. But what I need to understand is why are we prohibiting visitors to come in if one, the staff can come and go freely without having to be tested, so that would be like the same thing as a person from outside coming in and out the facility. And also there's a glass at CJC that separates the individuals from their family members. I have a coworker that goes and visits individuals inside of CJC and MSI on a daily basis. So another stressor is that they're not able to see their family members. The family members are not able to see their loved ones. So what is prohibiting CJC from allowing visitations?
I think there's a couple of things. CDC, one, is really solid about not recommending that you allow that. And I can give you some, I'll try to find what I can about that. But just looking at the facility over the last couple of days, each unit has 5 visiting rooms. You know, you come in the front door, you go up an elevator, then you go into that visiting area for the unit. And yes, you're behind glass, but you would have 5 people in there at a time that are not 6 feet apart. They would certainly be in there longer than 15 minutes. So you have some risk of families exposing each other. Of course, you're going to want to bring your children, your mom, a lot of people there. The second is it does create exposure for the guards who have to escort people up. So from a spreading situation that might occur. Secondly, the guards do get screened for signs and symptoms when they come in. So you'd have to set up a procedure for that, which would require staffing. You'd have to take temperatures. You'd have to, have them fill out a form. Have they traveled? Have they been exposed? All the things that you have to do when you go see the doctor or going to, go to a lot of places. That would require staffing that I don't think they have. They would have to escort people in, and they would have to sanitize between visits. So I don't think you could fully utilize the 5 spaces. You'd be, maybe 2.
Well, what about 2 of the spaces, or does it just seem like it's too much work?
It's not that it's too much work. It's that it increases potential of exposure to the people visiting and the guards, and they don't have the staff to do it.
So, right, they don't have the staff to do it.
Tracy, can I comment on that?
Yes, of course.
And we were going to bring this up this afternoon, but I just want to share that and I realize this isn't going to happen overnight, but the facility has pursued a contract to provide tablets to each and every inmate that is going to be able to do electronic visiting. I know that doesn't fix it today, but and they're working on a timeline for that, but they're hoping within 60 days that every single inmate in this facility has a tablet where they can get electronic visits. So that's in progress, and that's really I think kudos to the administration pursuing that. I mean, it took some time, and contract process is what it is, and technology is what it is, but that's going to be a great enhancement for the facility.
Thank you for that information, Brad. Yeah, thank you very much for that information.
I would add that our motivation has been to try to keep people healthy.
Right.
We have no desire for them. In my history of working in corrections, 2 things are true, and you're saying them. They need to have contact with their families. And being isolated in a room, even with the cellmate for a long time, is not healthy. We know that, we don't desire it, but we want them to be healthy from COVID, and we try to follow the rules that were established. And so that's why we find ourselves here. We want it to change. We can't wait for it to get back to normal.
And Commissioner Glass has been in communication with the health director this whole process. And I can't guarantee you that the health director is going to accept my recommendation. So that's why I wanted to start this as soon as possible, so that if he has questions, if he has concerns, if he wants to walk through this with me, that I don't think the health director is going to get this recommendation and go, oh, good idea. I think he's going to have some questions and concerns.
For what it's worth, I support it.
Yeah, thank you.
Again, Madam Chairman, I was
standpoint.
going to say, again, I renew my motion that we move ahead with your recommendations and get you started as soon as possible.
A second.
Okay. Thank you. I will get something in writing, better prepared, and to the mayor as soon as possible, making it clear that it's with your support. Oh, I'm sorry. We need a vote. And a second. Oh no, we got the second. Now let's do a roll call, because just for the record, I think Reverend Gray.
He's not on.
Oh, okay. So he and I did discuss it several times yesterday, so I know he's fine with it. Alderman Vaccaro.
I'm good with that.
Alderman Boyd.
Aye.
Senator Nasheed.
Aye.
Pastor Norris.
Aye.
Brad.
Aye.
Did I hear from Tracy yet?
Aye.
Is that everyone?
Dr. Walker, I don't know if someone's taking the notes right now, but I don't see Tanya on here. I don't know if she's having technical difficulties or what, but someone needs to, take the notes of this voted proposal.
Yes, ma'am, I've been taking notes and I will make sure it gets in the minutes correctly.
I'll take 5 minutes.
All right, keep going. Wait, let me ask, do you guys need a 5-minute break? Or you want to keep going?
Hey, I'd like to get it over with.
All right, I'm good.
Can I ask a question, Madam Chair? And you may have already done it. I had to go offline for a minute. Oh, okay. Oh, if you're in the middle of a vote,
Yeah, just say aye.
Aye.
Right, Mr. Pruitt?
What did I just vote aye to?
You sound like a politician.
Public servant. Well, the good thing is I've got confidence in the task force, and I know that none of us would lead any of us in a path that was not conducive to what we're doing.
Yeah, you're buying dinner for everybody. Don't worry. That's what we were voting on.
Well, I was going to borrow money from Senator Nasheed anyway, so that works.
We voted on what you and I discussed last night about moving my recommendation out of line, sort of, and getting it to the mayor as soon as possible.
Excellent. Well, then I've got, my vote is a 2 hands up. I wanted to ask, and you may have already done it. I know that Senator Nasheed and Ms. Staton at our last meeting was concerned about being able to interview detainees on the 5th floor. So I wanted to at least let the task force members know that Mr. Hump and Dr. Walker was given access to the 5th floor yesterday and did an interview with the detainee wing representatives there. And I don't know if, I suppose that debriefing will come this afternoon. But one of the things that I suggested, because I was not able to be there, that if there is an opportunity or we want to request an opportunity over the next couple of days, that myself and or Reverend Norris would be able to do that tour on the 5th floor as well. I know Reverend Norris wasn't available yesterday because of prior commitments, and he's kind of been the point person with the detainee interviews along with Brad and Dr. Walker. So I wanted to make sure the task force knew that interview on the 5th floor was done, and B, that I'm recommending that a follow-up be done by myself and or Reverend Norris for the 5th floor as well. So I wanted to bring that to the attention of the task force. And with that, I'll go back on mute, Madam Chair.
All right, Brad, you want to move the agenda?
Yeah, so we're going to move on to the facilities discussion. And as you know already from the media, there's a lock and door replacement project where there's been $1.5 million salary savings money due to vacancies moved to cover that project. So that's in progress. Unfortunately, those units, due to that pending project and the damage done in the disturbances, those units are offline, which is compounding some of the crowding and management issues here. But that is in progress.
Yeah, that's 198 beds they can't use until they get those locks fixed, and that is causing some stress, I think, on everybody.
So I just want everybody to know the status on that. But we also, in our data request, we requested other facilities issues, and I have in one of the pages that I wanted to discuss with the administration as a summary of funding requests specific to the facility and equipment needs for fiscal year 21. Just sharing with the group what those are and what the status of those are, and what precipitated those dollar amounts, or excuse me, those projects. And there are a number of them that are HVAC heating and ventilation. Heating and ventilation, air conditioning related, a number of electrical, and one plumbing. Some of these are general maintenance and some are upgrades. But I just wanted to have a general discussion about those. And as it relates to the HVAC, if any of those are due to making improvements so that we'll stabilize temperatures, if that's the reason for those, or if it's just general needs. So.
And can we talk about the tablets a little bit more? You know, how long you've been working on this and what you think needs to happen going forward to make it happen, and how fast that might or might not happen. Because I know some of that's facilities, docks and things like that.
Reference to the HVAC at this location, the most recent upgrade we had was air purifier. We added air purifier because of COVID to the HVAC at both buildings. We are already using hospital grade filters and all that, but we added that system as well. The rest of it is just routine maintenance. Last year, as I indicated at one point, we had the building automation system replaced completely in this building. It had not been done since the building was put in place, but the system has always worked well. It's just that it's so old, the software had not been updated, and because it had not been updated along the way in the last ever how many years, it wasn't possible to update it, had to be replaced. And some of the parts, actual parts, were no longer available. So we were very fortunate last year to have the funds to be able to replace the whole automation system.
And what does that drive?
Heat, air in the building, making sure that fresh air is mixed with the air in the building. That's a closed facility, closed building, as relates to that. So it drives all that. And it monitors temperatures, return air temperatures coming back to the return ducts, so that we make sure what that temperature is after it's been entered, but on its way back to the system. So that's all that is involved in that system. So that's basically what's happening now is just maintaining the system, regular costs, filters, things like that.
Are these submitted as requests or they approved?
No, so all of
You want to FaceTime me for a doggone it, man?
money's been
We've been hacked.
Uh-oh.
Yeah, so everything on this list, I mean, if a repair needs to be made, you know, if something breaks, then you probably speak to this too, but if it's something our maintenance staff can't fix, then we call in a contractor. There are contracted people through BPS that we use, electrical, mechanical, plumbing contractors, and they come and fix it. So the ones on this list are the ones that the money's already been encumbered and the work is either complete or nearly complete. But, you know, for example, if something broke last week and we had to call in a contractor, it would be on this list because, you know, my office and the business office doesn't have all the information yet. But honestly too, you know, with the budget the way it is, which I mean, the city is, you know, there are budget shortfalls. And so, you know, we're repairing things as they go, and we make upgrades as we need to.
One of the things we heard from the detainees that they would actually yell at us. My water doesn't work, the shower doesn't work. You know, how do you discover that? How do you respond to that? How do you pay to fix that?
So,
I mean, I know just a building this size, you're gonna have that kind of maintenance and issues. But
yeah, plumbing is an issue that is ongoing. Some of it is cost. I don't think we've had a lot, except for this recent incident, we had a lot of damage, but some of it's just time to be replaced and addressed. But our process for addressing those issues is not only do we request a certain amount in the budget related to those kind of repairs based on prior history, we also have a plumber on our staffing role for the division, and as well as maintenance crew. So we repair and fix when it's reported either by staff or by detainee, and if it's just discovered based on walkthroughs. We repair it. If we can't repair it, we call and have a approved contract provider come in and do that. But to see somebody repair some plumbing, that's probably normal for every day, here or the other location.
Madam Chair, I got a couple of questions. I'll deal with the plumbing first. I want to back up to the HVAC right after that, if it's possible. But I want to make sure on the plumbing, I remember when we met earlier, you mentioned about the detainees being able to flood the pods by stuffing things in the toilet, and that happening is not new. I mean, I'm familiar with that, but my assumption is that your inability to prevent that from happening on an ongoing basis, where you don't have to shut off water to the rest of the detainees, is because the plumbing is not bifurcated in a way where you can shut it off for a floor or for a pod. Is that the issue?
Oh, no. Yes, we can. We shut off. If one section is flooding, we don't turn off the water for the entire building. No, just that section.
So when we met earlier and we asked a question about detainees saying they did not have access to water for a period of time, I remember you said something about them flooding it out, and you did that. And when you told them once they stopped flooding it out, you would turn the water back on, but in between time, you would turn it on for maybe an hour at a time for them to do something and then shut it off. So I'm trying to reconcile that conversation with what I'm hearing now.
I think it's two different questions. The previous conversation was about a particular event.
Sure.
And you were asking me about that event and where was the truth in what was being said. Were we punishing them by turning off the water? And I spoke about an event where they were flooding, and we turned off the water because they were flooding, so they couldn't do that anymore. And then once that stopped, the water was back on. If it happened for any period of time, we would tell them what the water schedule was, in case, so that they could use it and they would know. But that hasn't happened.
So I'll make sure I'm clear. So when you say you gave them a water schedule, so that was just for that individual section?
That's correct.
Okay, now I understand. It was just for that individual section. Got it.
The one we spoke about, I wanted to try to bring some context to it. They were flooding, and they thought that we were punishing them. And we found that out by talking to them. But what had happened, we were involved in a maintenance repair. And when we were doing that and shut off the water, it didn't fully shut off, and we weren't aware of that. So we flooded. And they thought we were doing that to punish them in some way and turning off the water. As I indicated, the repair wasn't complete. We had to call in a contractor, and we didn't get it fixed till like 8:30 or so in the evening. But then there was water in places we weren't aware of. So it was like an almost all-night affair trying to get all the water up. Because they thought we were punishing them, they started flooding. So they made the issue much worse. And so
got it.
We didn't know what was going on. Sometimes that communication helps. And so they believed us, and we cleaned it up, and that was resolved.
Yeah, I better understand that. Now, going back to the HVAC and understand about the temperature, the air temperature and things of that nature, but the sensors take the temperature of the airflow coming in and out, but are you saying that that is indicative of the temperature in the entire room, say in the common area, and definitely in the individual cells? That temperature wouldn't be consistent throughout all of that space, would it?
So I don't want to try to speak more than what I know, but I can tell you that there are return ducts throughout the building. And so the temperatures are monitored in those return ducts. So the air is coming in warmer, and then it's monitored to the return ducts. Are there areas and situations that would cause an area not to be as warm as another? I can see that being possible, but we have a range that alarms if it drops below a certain temperature, and that air coming back would indicate if we were having that issue. One thing that makes it difficult to regulate it, although we haven't had an alarm, I don't know the last time we had an alarm saying it was out of whack, but the one thing that does happen in jails and prisons is that people try to regulate the temperature of their room. And so they'll block the doors from the air coming in under the door, and they'll also put toilet paper in the vents, and they're trying to regulate the temperature to where they live. Sometimes that will impact the system. But I can say that the system has not been impacted to the point where it tells us or sends us an alarm and says we need to go look at this.
So just so I understand physically the layout. So there are vents in each room?
Yes.
There's vents in each room. Okay. All right. I got it. Thank you.
Just for our clarification, other than this list and the lock project, are there other capital improvement projects pending or funded requested for?
Are there other needs you would like us to hear about?
No, we've been fortunate, except last year with the pandemic and resources being so low. We've been very fortunate about in the last few years, particularly with the federal funds coming in, to do a lot of repairs at both locations. And so I think we're pretty good.
Hey, Madam Chair.
Yes, sir.
So I just want to make sure I'm clear on the commissioner's response. So part of our charge specifically was to look at the fact that we have a facility that's over 20 years old, and there could be some substantial upgrades needed or reconfiguration or things of that nature as relates to the physical facility itself, my assumption. So are you saying that right now, other than the things that are on that summary list, the building is adequate under up to standards that you would prefer that it be at this point in time?
Let me add one thing. I want to add one thing. When we met, I think yesterday morning, three of us with the commissioners, we were planning out that day. We asked him if there were security issues that he needed that could not be discussed in public because of security. And that's one of the reasons we're closing the meeting this afternoon. And one is the 1.5 million for the doors. There's another one that's a $13 million issue, and we will discuss that in more detail this afternoon, but I don't want to discuss it here. And then there's equipment needs around their ability to respond to incidents, and we'll discuss that this afternoon too.
Okay, I'm fine with that. I wasn't asking for the specifics. I just wanted to make sure I understood that we're not saying that the building is good and we don't need anything.
Yeah, and is there stuff you feel like you can discuss publicly that you need?
Well, the building is good, but I'm never satisfied.
Well, yeah, that's what I'm asking.
But I think that we're at a point now with all the work that we've been doing that we address the major issues that would be above and beyond what I would get in a normal budget. Kim Maloney did remind me, my operations manager, that we have been addressing issues with the roof here, and there are spots that leak from time to time. And so that it could be a small project, or it could turn out to be something large. At MSI, we ended up replacing almost the entire roof and patching other places that need replacing. So with this being built in 2002, that's a possibility.
And we saw.
Pam, can I ask a question, Pam?
Yeah.
Or really, it's, I think as far as charge number 3, I think that the overall concern as relates to the building, from my understanding, is that I guess we're being asked also to make a determination and or recommendation about the building in its current stage, or is it conducive to the health and the safety of the occupants, both staff and detainee alike. So I guess, and we'll talk about this afternoon, but if there are things that we hear, things that we see as a result of our interviews and presentations that need to be forwarded to the mayor's office as relates to the condition of the building vis-a-vis safety and health, I think that's the fair questions and the appropriate questions that we've been tasked to ask. Is that where we're going with that, Madam Chair?
Yes, and I think all 3 of us are going to have something to say about the 2nd floor in private.
Okay.
And maybe some needs there and recommendations there. But yeah, this is your opportunity, Commissioner, to tell us, you know, what you need.
But Madam Chair, I just want to make sure, and I appreciate what you said, Reverend Gray, and I agree wholeheartedly, but I just want to make sure I'm clear on my request to the commissioner. No, my assumption is that 21st century or maybe 22nd century now, correction facilities of this nature have changed over the years, and there have been significant and dramatic improvements on facilities on how they house detainees, and that while you have addressed issues periodically along the way as they arise, that I'm not interested in fixing flat tires as they occur, if we can actually buy a run-on flat tire, for lack of a better term. In other words, if there's an opportunity to look at this facility and look at bringing it in line with what future facilities need to look like and can look like, if that means we're going to be on the cutting edge and making that determination and doing it, I just think it ought to be on the table. I don't know how realistic it may be for us to get the administration going forward to address it, but I think that this is the opportunity to put that on the table. A couple of good examples of just what I heard today about the visitations, that, you know, we have these rooms and there's some concern about cross-contamination of families and this and that. Is there a possibility of rethinking visitations and physically how that can happen? It may cost us space where we detain people or things of that nature. My point is, I just hope that you would look out of the box and use your experience over the years and what you've been dealing with. And there may be some things that are that can really catapult and put this jail facility on a level that it maybe is unseen anywhere else in the country if necessary. I think we ought to take advantage of your experience and what you've been dealing with to at least put that on the table.
So I'll try to not ramble. about that. But I would indicate that seldom have I been accused of being in the box. So I have tried to be very innovative with this facility and bringing it forward from where it was. I would indicate that, yes, you're correct. The jail process, systems, how they build jail, it evolves over time. And if you go across the country in 2000, 2002, most of the jails that were built look like this. And COVID has already added a new change to jail design, which we have already explored and looked at. And it's consistent with what I was trying to accomplish at MSI, where I established one unit to be a therapeutic unit, so to speak, where it was behavioral health. And that was cutting edge for the country. A few have been able to do that, but we had a unit identified. We had actually, Horizon had hired the appropriate mental health staff to man that unit. They were going to run the unit. We were just going to provide security. And we had partnerships in the community to hand off that person. So in the community, if they had a mental health issue or behavioral health issue, they ended up in jail. We would continue that treatment. They returned to the community, that treatment would continue. Those things were halted when the city determined that they would like to close that facility. In looking at if there was a need for a new facility, all those things are on the table. Can I do that here? I was asked that question at one point. It can be done here, except for the population. And I cannot get people to understand, it's hard to get people to understand, if they're not in the field, why you can't have 800 beds and 800 people. You can't run a jail level. So that's maybe outside of what you were talking about in terms of repair. But if you want me to tell you what I think we need to do going forward in the city in the direction we were headed, that was it. But that's not the only program that we led the country in this city as it relates to reentry. You know, we address the whole process from a perspective of mental health, medical health, drug treatment, and all those things. We had 100-some programs here before COVID. So I guess to try to not ramble and wrap it up, what I would indicate is that my desire is for this building to be populated in such a way that we could offer the programs that really speak to why people come to prison or come to jail. And population, configuration, space available, all those things impact your ability to deliver services. I'm not saying anything astonishing. Everybody in this field knows that. And so we're quite progressive in that respect. In fact, we've been contacted by like the Bill Gates organization, state of California contacted me about our occupational therapist program and how we got that into our contract, and a number of things that we do. The final thing I'll say is that we've alluded to it, but having the tablets for the detainees that they have in their unit is about a lot more than visiting. It's about stopping drugs coming into the facility. It's about being able to read books through the tablet. It's about holding people accountable for medical appointments, responding to IRRs, being able to do a text message with your family. When we were doing our pilot program, and I went to talk to the women about how that was working, and the young lady turned the tablet around to show me where she had pictures of all her family that she could look at whenever she wanted. And you know, that was impactful in terms of a person that's isolated. So yes, those things are out there.
I want you to talk about that a minute. I did not know until we did the tour that they have tablets on the units already. Some units have 10, some have 2, but talk about that, some of the issues around that.
Well, you know,
They can't do Zoom on them, but.
yeah, no, so I'll talk about what I think I can.
Okay.
So we tried to get tablets here many years ago. And about, I don't know, maybe you can help me, who remembers better than me, but at least 3 years ago, we had a pilot program through our phone provider to look at tablets and how it would work, what were the limitations, what kind of infrastructure did you have to develop? And because some issue between those two entities, the pilot program stalled and never went forward. And we never got more tablets, and we haven't been able to support the few we have. But so recently, we actually, I think it was December is when we finally got that contract going for the tablets now.
It was just.
Yeah, so in December, we started that process. In earnest, got the city on board, and E&A signed approval, and the final information contract was passed on to the company, and they're going to be here Monday to look at infrastructure and expand that so that each individual will have that access for their own. And that'll give them opportunity to speak to their family in the evenings or see them or whatever that tablet can bring to us.
And after the company comes in next week, you'll have a better timeline for when you
Yeah.
think that might
They've given
happen.
a tentative schedule of 60 days until it goes live, because they have to, do the infrastructure, and then they have to train people on how to use them. There's some back office software.
So would you probably do like one floor at a time?
I'm not sure about that. We'll talk about how exactly, because some infrastructure may already be there. And so they'll need to come and assess what they need to add.
Yeah.
But 60 days is a long time, because we've already been a year with limited
And
access.
I
to
think
them.
communication will be important about that, is you get some units that have them, some
Oh, definitely.
detainees that have them and some that don't.
They'll know Monday when they see people in the building
Yeah.
that something's going on.
Yeah.
That's how it works.
Right.
And my,
Madam Chair.
Madam Chair. Then they flip the switch and they all work forever. Okay.
Yeah,
Yes.
Madam Chair.
Yes.
So I'm very familiar with what can happen with the tablets. I've known years ago about the how they evolved out on the West Coast and some of the correctional facilities out there. So I'm very familiar with it. I'm glad to see it. And I think from a continual education standpoint, there's a lot of things. But the Reverend Gray indicated that if we had recommendations that we need to submit them. So I'm going to ask the commissioner if he can summarize in writing all of the things he just spoke about and provide it to us. And Madam Chairman, that is going to be the recommendation that I have to be included within our report, because I think it is extremely important that we look at what our facility needs to look like in the future, and we put that on the table, and we clearly define and delineate that need is essential. And I shut up, and Senator Nasheed has her hand up, Madam Chairman.
All right, Senator.
Yes, Commissioner, can you say it? I don't know if you said it before in past meetings, but what is the annual operating budget for the facility?
Yes, it was
For this facility.
for this facility, 28 million. I think.
Approximately 28 million. That, I think we offered that in our document that was requested, and it's also online, but I think it's approximately 28 million, a little more.
Okay, and is it somewhere where it's itemized, where the funding in terms of administration, facility maintenance, and all of that?
Yes.
It's online.
It's online. Okay, thanks.
Yes.
So it was provided.
We provided it in a flash drive, and it's also on the city's website.
Okay.
We got a lot of data, just
It was all sent to everyone.
my days are running together, but was it yesterday or the day before?
Monday.
I know, but what day did you send it?
Monday.
So look in your email, because you got a whole data dump on Monday.
And that's inside, okay.
One place, yeah.
Madam Chair, I have another question. Commissioner, is there an update on the time frame in which those locks will be repaired? I know initially, I know that the Board of E&A made the allocation 1.5 million or so. I think it was indicated that 10 to 12 weeks was the suggested time frame. Has that been adjusted at all?
So without getting into security issues, I would indicate that they're scheduled to be here again Monday. The repairs might be a little more extensive. So I don't know, George, did they change the timeline or have we heard any update on that?
Yes, it's going to actually be March the 15th.
Is when they're scheduled to be here. Okay, March 15th, but any timeline, have we had an update on how long it will take to repair?
No.
No, so we've had no update on that, but I'm anticipating an update because they've indicated that the repairs may be more extensive.
All right, and then a follow-up question, and Madam Chair, indulge me. I'm hoping that this fits within the preview of this conversation. And it may go back when you talk about the utilization of correctional officers to assist or augment providing services to detainees. Do you have your full complement of correctional officers? And if not, how many more officers do you need in order to have your full complement, or something that is reasonable based upon the number of detainees that you have there now?
So in terms of what is authorized, which is something different from what I would indicate I need, we're down approximately 88 staff. And we just interviewed, what was it, George, 60?
No, actually about over a couple hundred.
Yeah. I mean, the last set of interviews.
Yes.
So we a month ago, we hired about 12 people, then 10, and now we just interviewed about 60 people. Is that right?
Yes.
Yes, about 60. So we're working on it. And of course, like any law enforcement, training takes a couple of months at least, if not longer, not counting the OJT. So it'll be a while before they're actually able to work on their own. But that process has begun.
Okay, thank you very much. Thank you, Madam Chair, for indulging me that question.
88, is that for this facility only? So I remember some conversation whether that 88 was between the two facilities.
It is for the division, but I don't know the exact split, but it's pretty small in the size. Most of them are here.
Most of them are. That is.
And so you're 88 now. How many do you have total? How many?
198 officers here.
Well, that's just correctional on
Correctional
CO1.
CO1, right.
You don't have that's what, you don't have 182.
No, that's what we're authorized.
Right, that's what we're authorized, right.
How many more did you ask for?
I asked for, give me my side clothes, I want response teams, about 20.
Right.
20 more, is that sound right?
Yeah.
Yeah, about 20 more than authorized.
According to the numbers, the other day, 198, CO1, 79, CO2, 6 captains, 1 chief of security.
That's correct.
Hey, Madam Chairman, I have one other quick follow-up question for the commissioner. I know we talked about the summary for funding, and I know we talked a little bit about all the other things. Should we also assume that because the the courts, and I think everybody else has made it clear that there's a multi-agency utilization of the building in different areas for different things. So should we assume that this summary and the fixes and all these other things include the areas that they occupy and utilize, or is this just as relates to your functions?
No, it goes broader than my functions.
Okay, got it. Thank you.
Anything else as far as questions on facilities? And like I said, we do have other items that we'll debrief on later as far as facilities equipment. Just a couple other brief discussions with the administration, and we will also debrief on this later, but we still have to hear from the public defender's office. And obviously one of the themes that we continue to hear and see here is the length of stay for pre-trial, before trial. And actually what we're seeing is it's not only just pre-trial, it's pre-charge. There's many people being detained here for months and years, not even charged with a crime. And we'll get into that later, but I just wanted to have the discussion with the administration about, I guess, concerns or mitigation processes to deal with that. And I understand it's out of their hands, but how we, the concerns that brings up and how they mitigate that as far as in the jail itself. I don't know if you had any comment on that.
Well, yeah, I'm still trying in my mind to sort out the statement and put it into the form of a question that I can respond to. I'm sorry, but I would indicate that what I can say, and I think is significant, is that the length of stay has increased. Prior to COVID, the average length of stay was 220 something days. After COVID, just looked this morning, it was 346 average length of stay. You got some people that come here for a few minutes, and you got people that stay here for years. We met one that's been here 9 years. So, I'm saying, yeah, that's the average length of stay. It's hard to put it into context because some it's really a great deal of time, beyond 200 or 300 and some days. And there's some that's just maybe an hour or so. So that's the average. And even this last year during COVID, the population has, of course, obviously, since there's not a lot of movement, has actually increased, probably by 40 people or something like that. So the average population has increased as well. And then even what's also relevant is with the COVID restrictions, it's hard for people to even move through the building when you quarantine them 14 days and then somebody else is waiting for that bed that's in the building. That whole process is impacted. The one thing too is that there are a number of entities in the building, not just us. But Brad, I think there was something else in that statement, but I don't know if I answered it.
Well, just basically what I'm looking at is any commentary and what you would have on the length of stay issues and the issues that causes for you and what you have to do to mitigate that. We're aware of if we have the data as far as the length of stay, the number of pending felony cases, and it's really shedding light as the more people we talk to. Some people where the average length of stay is 344 days, like the Reverend said, there's people been here 6, 7, 8 years in a county jail when they haven't gone to trial, and there's actually what we're finding out is people every year.
So I can make some general statements.
Sure.
Jail is a great deal more restrictive than a prison. prison, we're talking about, I mentioned this yesterday, we're talking about locking devices. In the prison that I was the deputy warden, each individual had the key to their room. Jails were not intended originally for people to stay this long. It adds up, you know, even just be able to go outside and walk, you know, so it adds to that issue of being incarcerated. It's magnified by that fact. As you rightly indicate, we don't have any control over that issue. We don't determine when they come or when they go. We try to put programs in place so that we have frequent flyers, people come and go all the time. We try to put programs in place so they won't come back. That's how we try to address the issue of the number of people that we incarcerated. In fact, dropping from 2,000 people when I arrived here to where we are has a lot to do with partnerships with the community and programs we put in place. Not to exclude the Bell Project, but that was just one program that I put in place. I allowed them access and helped them figure out who was who. So that's a big issue prior to COVID. Now at COVID, and the movement has really slowed down. People that stay here for the long periods of time, they're harder to manage. They're more likely to damage equipment. It's just a fact. And so I'm sure there's somebody smarter than me who can talk about that correlation and what they're dealing with being this isolated. But those things are true. Those things have been exacerbated by COVID. Yes, so what do we do? Prior to COVID, like I said, we had 100-something programs. We still have a good partnership with so many agencies in the community. We fixed the one thing I saw was that volunteers, there was a wealth of volunteers in this city that wanted to work, that wanted to help people, and they were having trouble getting in. And so I fixed that so they could come in. And in fact, I tried to let my staff know that we can't do this job alone. We need them. Now, in the prison setting, they were also eyes and ears, because even though I think I can talk to a detainee and be straightforward with them, and they can talk to me, there are some people that won't say things to us, even though we don't understand why, but it's just real. They may not believe us. They don't trust us. We represent the police, the courts, and everybody that they think is their enemy. But volunteers see things and they tell me, hey, this is going on upstairs that you may not know about. And so we take that broad approach that everybody comes in here is helping us to make sure we do the right thing, the best that we can. So that's what we did. We tried programs, activities, and all those things are very important. And they were all but eliminated with COVID, because some wouldn't come in, and even those that we thought we would be willing to let come in with masks because we thought they were professionals in the field, they were one of us. They didn't want to come in. They were afraid to come in. Or their agency said they couldn't come in, trying to protect their employees. And so, yeah, we've been kind of like trying to do this the best we can. And COVID is difficult, but I want to keep them safe, so.
A follow-up question to that is, I shared an article, I guess this morning, with the task force that analyzed this issue nationwide. Yes. And basically, the professionals on the justice side are saying they don't see this even beginning to get addressed until sometime in 2022, and that's optimistic. And I honestly don't see how this can continue without this place having more incidents and uprisings. And I'm just wondering, you know, what you guys' thoughts are about continuing the marriage under this, you know, really very unacceptable situation.
I want to share all my thoughts.
As you can see, I don't hesitate to share mine.
But I can tell you that them visiting is important. It's always been an important issue to me. And most would say that a lot of the things that I do, I'm too lenient or too far to one direction. But I, over the years, know the impact and the importance of those issues. But one of my primary charges is to try to make sure that they are healthy. And so those two butt up against each other. A solution to that would be great. So I tried, like I said, I tried to follow what I thought CDC said, and with the help of Horizon and Health Department, I did those things that I thought was necessary. But
I think they were. You know, I hope you don't think that my change in the recommendations, a judgment of what you've done.
Well,
because we didn't know what we know now.
Yeah, and right around December, we had been at 0 for 2 months, no cases, no known positives. I had conversation with the health department about can we resume visiting? We've got the shields, and although, like you indicated, those people would be close together, and one of the areas has a pass through and all that. And we got to the point where he said, well, let's do a walkthrough and talk about that. And then in December, there was an outbreak in the community, and there was an outbreak here. We had some more positive cases, so we said, we better stop out of abundance of caution for people's health. And so I long to be able to go back to where they can see their family. And the tablet thing is to get a contract approved and through is a process. Even though there's some glimmer of hope and light in 2 months, that's 2 months added to a year. So those are my concerns, but that's what we're trying to do. And as I indicated, we go and talk to the staff, to the detainees, and answer their questions and their concerns, what we know them to be. But the answer's the same, and nothing's changed. So that's the problem that I see. And again, we want to look at the visiting issue of the safe. We're hoping that they can get the tablets to us before they say. That's what we're doing. And even the idea of introducing some more programs here would be great. We got a couple where we've been able to use monitors to continue classes, but not much because we're just limited in that area in terms of course, they can't have internet, and the building's not conducive to Wi-Fi because of all the metal and all that kind of thing. But that's what we're hoping. Hoping we move forward with visiting, programming, and tablets, some semblance to where we were before. The other things too, because we've also increased mental health contacts, and we have them going through the building, talking to inmates and staff for that matter. In a lot of cases, what I observed is that the detainees react the same way the community does, only magnified. They're no different.
It's interesting you mentioned mental health in our interviews. The perspective on mental health access relative to medical is completely opposite.
Yeah, I'm surprised on that.
They're like, oh, you mental health, no problem.
Yeah, I'm not surprised that they would say that to mental health, but I was surprised about what they said about medical. And maybe Christina explained it. I know we get that a lot, that they're not getting what they think they should get. But their primary care doctor now is Dr. Mallory. She's their primary care. So
I think there's a big difference between being seen and being treated. Something like it.
I'll be anxious to hear what you guys find.
Any other questions or concerns on that issue?
What issue are we talking about?
Trying to keep on that. That was the length of stay issue as far as what that.
So we're going to talk to the public defenders tomorrow, right?
Yep.
And we've gotten letters from this court task force, whatever they're called. CJCC, that we should probably all look at. And really sort of drill down in our recommendations on that. Tomorrow, we've got another closed session tomorrow to talk about that. Because, you know, frankly, I don't see why the courts aren't doing Zoom jury selection and Zoom plea bargains and, you know, catch up, you know, saying that they're not going to deal with this for another 1.5 to 2 years. That's not going to work. That's not going to work nationwide. So I'd really like us to think out of the box and push on St. Louis, like you were saying about the facility, Adolphus. Let's be progressive and let's be a pilot. We can move this docket in a creative and smarter way than just saying, oh, we don't know what to do. It's not acceptable. And I don't think it's constitutional, but you know, that's somebody else's case. Go ahead, Tracy.
Yeah, I was just wanting to second what you said because you know there was a stall on court cases with people that are not detained, and there was a solution, you know, to that situation with WebEx, and that is that's what's being done, and they're even holding some in person. They are holding some people from outside or coming inside the courtrooms to have their court appearances and things of that nature. So there is no way that we can continue without people having their court dates and making court appearances. So like you said, and like Mr. Pruitt said about being progressive, that is something that has to happen. It's imperative. And I do believe it's unconstitutional, and it's definitely creating anxiety, fear, frustration, irritation, aggravation with the people that are being detained because they do not know. There's no certainty. It's so much uncertainty around what is happening with their case and when they will go to court. And it's imperative that we definitely make a recommendation to do something about that issue.
I've got several, but I'm not an expert in that field. So when we get to that, I'll throw them out there and you guys can shoot them down or not. But I think in our closed session, you know, come prepared for that tomorrow with some recommendations we can all get on board with.
Madam Chair, I'm sorry. Go ahead. Go ahead.
No, go ahead.
I just wanted to mention two things. One, a housekeeping, and the other one is tomorrow. And Brad, Mr. Pruitt asked me to reach out to the sheriff's office to see if someone from his office can come in for a Q&A. We wanted to understand the relationship of the sheriff's office and CJC and the 22nd Judicial Circuit. And so they've agreed. And so tomorrow, my understanding as far as the schedule, from 9 to 10, we'll have the public defenders. From 10 to 10:30, we'll have the sheriff's office. From 10:30 to 11, we'll have Expo. And then Congresswoman Bush is simply she'll have her staff available, but they wanted to simply read information from the Congresswoman's office. So that was the time frame that we would be operating in tomorrow with those presentations. So I wanted to at least make sure that people knew that. And I just want to make sure for protocol's sake, Madam Chair, that before we conclude this meeting, that we take a vote, that it be on the record, because we discussed it, but I'm not sure, looking back at the minutes, that we actually voted to go into closed session at 1. We did discuss it. I know we agreed, maybe we agreed by consensus, but I'm not sure if we need an actual vote. Maybe one of the aldermen can tell me. we did agree by consensus, but do we need an actual vote at this meeting, even though it's been announced that we go into closed meeting? So I just wanted to make sure we follow protocol on that.
We were told that when we come back together at 1, we need to make, because we're basically still going to be in the same meeting. We're just going to break for lunch.
Got you.
And when we come back in at 1, somebody needs to make the motion to go into closed session due to security reasons. And then after we're done with that, we come back out of closed session for adjournment.
Okay, thank you very much.
Okay, I think we've covered the activities and budgetary and staffing discussion. And like Pam said, we've had that discussion with them earlier, and we'll have information on that this afternoon's debrief. So I guess if anybody has any follow-up questions for.
I have a question. Pam, I just want to make sure that you all are spoken with attorneys. I know that there's been issues with, Sunshine and just following the Sunshine request. And I know we're going into closed session. So I just want to make sure that everything is legit. There's no backlash. You've already spoken with attorneys to see how we move forward with our meetings and transparency.
Yes, we've been following the guidance from the mayor's office on how to manage this and following their advice to the letter. The reason we couldn't have a closed meeting yesterday was because we didn't post it in time. So we're following the posting requirements. And we felt that, and we've got approval to close because some of the things that we want to discuss could possibly reveal who we may have talked to. It possibly could reveal some of the security issues that show where the weak points are in the building and in staffing. And so we need to, I think, have a fair discussion of what those of us who had heard so that we can then.
And I understand that. But my question is, did you all, did the administration that's overseeing our meetings and posts, did they post 24 hours ago for the closed meet that there will be a closed meeting publicly?
Yes, ma'am, they did.
Okay.
They posted our agenda and it says that we will go in closed meeting as needed for security reasons. And then when we come back out, we'll have to figure out how to, because we'll have recommendations related to those things. And we will have to figure out how to word those, and that all has to be public. So after our closed meetings, we're still going to have a meeting, I think, to approve all the recommendations, approve the report. That may have to happen next week after we all get time to write stuff. But that all has to be public. It should be. I'm not, I said have to be, but because of the law, but we need to do, we're all committed to maximum transparency.
Yeah, thank you.
Anybody else have anything else for the good of the order this morning? Or questions for the administration? Otherwise, I think we have covered the topics and we can reconvene at 1.
Sounds great.
Sounds like a plan.
All right, we'll see everybody at 1. Reverend Gray, you get to take back over when we go into closed session.
It's fine. I'm just going to follow your lead. Thank you very much. Thank you very much for stepping in this morning. And I look forward to talking to you guys this afternoon. Be safe.